Hi guys, this presentation is entitled Colorectal Cancer, an Overview. In the following slides, I will cover general information, signs and symptoms, diagnostics, management, complications, and referrals of a colorectal cancer diagnosis. Starting off with general information, colorectal cancer, which I'll abbreviate as CRC from this point on, is unfortunately a disease process pretty commonly encountered in practice. Even more unfortunately, its prevalence is on the rise in the U.S. as well. As it stands now, CRC with respect to major cancers is second in overall mortality and third in overall incidence. So how does it start? Nearly all forms of CRC begin as what we term precancerous polyps, or small masses of tissue made of cells that are predisposed to malignancy. If caught early by screening measures, polyps provide a window for preventing development of full-blown neoplasm. They arise out of the epithelium and into the intestinal lumen. They're further subdivided based on their histology, and each type of polyp carries its own risk of developing into CRC. The three main categories of precancerous polyps are tubular, tubulovillous, and villous adenomas. Tubular adenomas are the most common and are considered to have the least amount of risk. Villous adenomas, in contrast, are the least common but carry the highest risk of developing into malignancy. Tubulovillous adenomas are thought to be intermediate in frequency and risk. As with nearly any other type of cancer, there's no guarantee whether or not someone will develop CRC, but there are certain risk factors that increase their chances of developing the condition. These risk factors can be broadly categorized into age, genetics, and environmental sources. With respect to age, it's pretty simple. Risk increases as age increases. In terms of genetics, risk increases with autoimmune conditions like IBD, family history of CRC in a first-degree relative, and/or familial cancer syndromes like Lynch syndrome. Lastly, concerning environmental factors, risk increases with the use of alcohol and tobacco products, high-fat and protein diets, long-term bowel habit changes like chronic constipation, lack of physical activity, and abdominal radiation. Clinical assessment and disease course. CRC is typically a very slow-growing cancer. Most early stages are asymptomatic and are only discovered secondary to routine screening measures. However, due to dismally low compliance rates with screening colonoscopies, the majority of CRC cases are already in the metastatic stages when initial care is sought. As the disease progresses and patients begin to develop symptoms, they typically note changes in bowel habits and stool, as well as hematochezia, unintentional weight loss, a waning appetite, and diffuse abdominal pain. Depending on if the lesion is located on the right side of the colon, this would be your ascending colon, or left side, descending or sigmoid colon, certain symptoms are more common. So for our left-sided cancers, they're more likely to result in abdominal cramping and obstructive symptoms. As a result, they tend to present more commonly with hematochezia, so frank red blood per the rectum, changes in bowel habits, this is when you'd see that pencil-thin stool presentation, and perianal pain. Right-sided colorectal cancers are more proximal in the colon. They tend to ulcerate more than left-sided will. As a result, right-sided CRCs more commonly experience iron deficiency anemia secondary to GI bleeding, melena, abdominal pain, weight loss, and fatigue. In terms of metastases, CRC likes to spread to the liver, lungs, peritoneum, and the regional lymph nodes. For diagnostics, based on current USPSTF guidelines, screening for colorectal cancer should begin at age 45 and continue until age 75. After the age of 75, it really becomes a case-by-case basis, typically determined by a conversation between the provider and the patient, with consideration of the patient's risk factors, provider recommendations, and patient wishes of whether or not they intend to proceed with screening measures at all given their age. Many different methods are used to screen for CRC, and each method carries its own repeat interval requirement. Colonoscopies are typically done every 10 years. Fecal occult blood stool tests, or FOBTs, are done annually. CT colonographies are done every 5 years, and flexible sigmoidoscopies are done every 5 years as well. Colonoscopies are typically considered to be among the most accurate of screening methods, and therefore they're often preferred by providers. It's also important to note that FOBTs, if they are positive, are going to require a colonoscopy follow-up to determine the source of that bleeding. So even if they do the FOBT originally, in any case that it comes back positive, they'll need a colonoscopy anyway. Screening intervals are subject to change based on quite a few different factors. After a diagnosis of IBD, for example, patients typically get colonoscopies to screen for CRC about every 3 years, although it can vary to some degree by practice and provider preference. Patients with a history of CRC and one or more first-degree relatives should start screening colonoscopies at age 40 or 10 years prior to the age at which that relative was diagnosed. Really, whichever one of these comes first. Once polyps are seen on a colonoscopy, particularly higher risk polyps, future colonoscopies for that patient are typically done at 5-year intervals rather than 10-year intervals. And so once we have this diagnosis of potential colorectal cancer, we have to confirm it with a tissue biopsy. And that's typically done by a colonoscopy regardless of the screening method that was initially used. Once we confirm CRC histologically, a CT abdomen, pelvis, and chest is used to further stage the cancer. So for treatment, any case of colorectal cancer treatment tends to be a multimodal approach. Historically, treatment for colorectal cancer has included options of radiation, surgical resection, chemo, or a combination thereof. Treatment for each case really depends on staging and that patient's prognostic factors. So their personal comorbidities, whether they're a stable surgical candidate, things like that. A specific case-by-case management can get pretty complex. I'll primarily give an overview of what's needed for each stage from more of a primary care standpoint. So for early stage 1 cancers, these cancers are going to be a localized malignancy that has invaded through the colonic mucosa into the colonic muscle, but it hasn't yet invaded into adjacent organs or regional lymph nodes. And so for these cancers, surgical resection tends to be the primary course of action. For stage 2 cancers, it's invaded beyond the colonic wall, but it hasn't yet quite reached those regional lymph nodes. And in stage 3 cancers, where malignancy has reached those regional lymph nodes, but it hasn't yet spread to other distant organs, meaning there's no distant metastases yet. So for both stage 3 and stage 2, local resection with adjuvant chemo is most often standard of care. So surgical resection followed by chemo. Depending on the size of the tumor, neoadjuvant radiation may be completed prior to surgery to shrink the mass before resection. And this may just make surgery more safe for the patient, or it may make it more effective and have a higher likelihood of remission. For metastatic cases, systemic chemotherapy, which is often palliative depending on the remaining clinical picture, is most frequently recommended. Immunotherapy is also gaining traction with respect to management of colorectal cancers. Several clinical trials are ongoing globally, including in the US, and some hospitals are beginning to incorporate immunotherapy into their protocols. Options for specific drug classes and methods in immunotherapy include immune checkpoint inhibitors, monoclonal antibodies, oncolytic virus therapy, and adoptive cell transfer. As it stands right now, however, the classic approaches I kind of outlined above are still technically standard of care. Immunotherapy is on more of the experimental side, but it is making great strides currently, and hopefully in a few years to a few decades, we'll start to see it incorporate a lot more into standard treatment plans. For complications and referrals, complications of CRC includes metastasis, as you see with virtually any other cancer. You may also see iron deficiency anemia in patients secondary to GI blood loss, constipation, which is often due to obstructive neoplastic tissue, so the mass, depending on its size, may be large enough that it invades the lumen to such a degree that it's blocking that stool from moving through the colon and results in that constipation. And you can also see a complication of recurrence of the primary cancer. In terms of referrals, all CRC patients, once they're diagnosed, really need to be referred to 3 providers: a radiation oncologist, a medical oncologist, and a colorectal surgeon. Okay, so that's it for this presentation. Here's a list of references that I used to compile this presentation. Thanks for watching, and of course, let me know if you have any questions.